Hello, everyone. Before we begin, I want you to think about something for a moment. Have you ever craved a cup of coffee in the morning and felt irritable without it? Or noticed that one cup no longer feels like enough? That simple experience is your first glimpse into the world of addiction. Today, we'll explore one of the most important topics in medicine, addiction. So, what exactly is addiction? Addiction is a chronic, relapsing disorder characterized by compulsive drug seeking, continued use despite harmful consequences, and long lasting changes in the brain. In pharmacology, we distinguish between the behavioral patterns of addiction and the physiological adaptations of the body, and you will understand exactly why a person who wants to stop often simply cannot. And here is something I want you to hold on to throughout this entire video. Addiction is not just a habit. It is not a moral failing. It involves long-term, measurable changes in brain structure and function. Now, here is where students often get confused, and understandably so. To understand addiction properly, we must first distinguish between three overlapping but distinct concepts: dependence, tolerance, and withdrawal. Let's break each one down. First is dependence. It refers to the adaptive state of the body in response to repeated drug exposure, manifesting as a physical withdrawal syndrome when the drug is stopped. Think of it this way: the body is remarkably adaptive. When a drug keeps showing up, the body says, "Fine, I'll reorganize around it." The problem? When the drug disappears, the body is suddenly out of balance. There are two types. 1. Physical dependence. The body becomes physiologically adjusted to the drug. When the drug is stopped, withdrawal symptoms occur. For example, opioid withdrawal leads to sweating, diarrhea, and severe pain. Patients often describe it as the worst flu of their life, except it does not go away on its own without intervention. 2. Psychological dependence. This is an emotional or mental craving for the drug. Ask yourself, why do recovering addicts relapse years after getting clean, even when they have no physical symptoms? That is psychological dependence at work. It is driven by the desire for pleasure, euphoria, or relief from stress. It is strongly linked to the brain's dopamine reward pathways. Next is tolerance. It is a state where repeated administration of a drug results in a reduced effect, requiring larger doses to achieve the same original response. Here is a quick question for the group. If a patient tells you their prescribed painkiller doesn't work as well as it used to, what might be happening? That's right, tolerance. And it is one of the earliest warning signs we look for. There are 4 types of tolerance. 1. Pharmacokinetic tolerance. The body metabolizes the drug faster. Example: alcohol induces liver enzymes, specifically CYP2E1, leading to faster breakdown of the drug. This is why chronic alcohol users may need higher doses of certain medications for them to work. 2. Pharmacodynamic tolerance. Adaptation occurs at the receptor level. There are fewer receptors or reduced receptor sensitivity. 3. Cross-tolerance. Tolerance to one drug reduces the response to another similar drug. Example: alcohol and benzodiazepines share cross-tolerance. And fourth is acute tolerance, also called tachyphylaxis. This is a rapid development of tolerance within hours or days. A classic example: nitrate drugs used in angina. Patients can become tolerant to them within just 24 hours. This is why we prescribe nitrate-free intervals. The last one is withdrawal, which is the set of symptoms that appear when drug use is reduced or stopped. And here is the key insight that will help you remember this forever. It occurs because the body has adapted to the presence of the drug. And here is the golden rule: withdrawal symptoms are almost always the opposite of the drug's effects. If the drug sedates, withdrawal agitates. If the drug relieves pain, withdrawal causes pain. Once you understand that principle, you can predict withdrawal symptoms for almost any drug. For example, in opioid withdrawal, patients experience intense discomfort, including pain, diarrhea, and lacrimation. In alcohol withdrawal, symptoms can be much more dangerous, ranging from tremors to seizures, and in severe cases, delirium tremens. And in nicotine withdrawal, the symptoms are more psychological, such as irritability and anxiety. The severity of withdrawal depends on the type of drug, the duration of use, and the dose consumed. Now that we understand what addiction is, the real question is, what is actually happening inside the brain? This is where pharmacology meets neuroscience, and where the real story of addiction begins. The reward pathway is the primary circuit involved. Here is a statement I want you to memorize and never forget. Virtually all addictive drugs, regardless of their chemical structure, share one common final action. They all increase dopamine concentration in specific brain regions, all of them. That is the unifying principle of addiction pharmacology. To understand this, we need to zoom into a very specific circuit, the brain's reward pathway, the mesolimbic dopamine system. This pathway is often called the brain's pleasure center, though that label is a bit of an oversimplification. Think of it less like a pleasure button and more like a survival priority system. It tells the brain, "This matters, do it again." It consists of three key components: ventral tegmental area, VTA. Think of this as the factory. This is where dopamine-producing neurons live and where the signal originates. Nucleus accumbens, NAC. This is the delivery destination. Dopamine floods here to signal reward and reinforcement. If you remember only one brain region from this lecture, let it be this one: prefrontal cortex. This is the brain's CEO, responsible for decision-making and impulse control. Crucially, this area is progressively impaired in chronic addiction, and that is why telling a patient to just stop is not only unhelpful, it is scientifically uninformed. Their impulse control center is literally compromised. Remember, all addictive drugs increase dopamine levels in this pathway. Now that we understand the reward pathway, the next question is, how do drugs actually increase dopamine? Interestingly, different drugs use different strategies, but they all arrive at the same destination: a dopamine surge. Starting with increased dopamine release. Some drugs take a direct approach. Drugs like amphetamines essentially force neurons to release large amounts of dopamine. Instead of waiting for a natural signal, they push dopamine out in excess, flooding the system. Next, dopamine reuptake inhibition. Other drugs work more subtly, but just as powerfully. Take cocaine, for example. Normally, once dopamine is released, it is quickly taken back up into the neuron. Cocaine blocks this reuptake process, so dopamine stays in the synapse longer, and the signal becomes stronger and prolonged. 3. Disinhibition mechanism. Now here's a very clever mechanism. Some drugs don't act on dopamine directly at all. Instead, they inhibit GABA, the brain's natural braking system, and when you remove the brake, dopamine neurons become overactive. The result? A surge in dopamine, indirectly, but very effectively. Example: benzodiazepines or alcohol. 4. Receptor-level effects. And finally, some drugs act at the receptor level. Opioids, for instance, bind to mu receptors in the brain. This creates powerful reward signals and also contributes to pain relief. But at the same time, it strongly reinforces drug-taking behavior. But the story doesn't end with dopamine surges. Here is where it gets really important and sobering. With repeated drug use, the brain adapts in a way that works against the person. It reduces natural dopamine production. It decreases receptor sensitivity. The result? Normal activities, food, laughter, connection, no longer feel pleasurable. The drug is no longer taken to feel good. It is taken just to feel normal. This is the biological trap of addiction, and it is why recovery is so much harder than simply choosing to stop. Now let's go through the major classes of drugs of abuse, and as we do, keep one key question in mind. How does each of these increase dopamine in the mesolimbic pathway? Opioids. like morphine and heroin, they activate mu receptors, which ultimately increase dopamine release. This is why they produce strong euphoria, but also a high risk of physical dependence. CNS depressants, such as alcohol and benzodiazepines, they enhance GABA activity, leading to sedation and relaxation. But importantly, withdrawal can be life-threatening, making them particularly dangerous. Stimulants, like cocaine and amphetamines, these directly increase dopamine levels, producing intense euphoria. That's why they are associated with high psychological dependence. Nicotine. It activates nicotinic receptors and rapidly boosts dopamine release. Because it reaches the brain so quickly, it is extremely addictive. Cannabis acts on CB1 cannabinoid receptors. It increases dopamine more moderately, so it has a lower, but still significant, addiction potential. So despite their differences, all of these drugs share one common pathway. They hijack the brain's reward system by increasing dopamine. Here is something critically important for clinical practice. Addiction does not happen overnight. No patient wakes up one day and decides to become addicted. It is a gradual progression through 5 stages, and recognizing the early stages is where we, as clinicians, can intervene. Stage 1. Initiation. This is the first, yes. It's often voluntary, driven by curiosity or a prescription. At this point, the brain is still biologically healthy. Stage 2. Reinforcement. Here, the brain learns the reward. The dopamine surge feels good, and the behavior is reinforced. This is where brief intervention can be most effective. Stage 3. Tolerance. Now, neuroadaptation has begun. Because the brain has fewer receptors, the original dose doesn't work anymore. The user scales up the dose, and the slide toward addiction accelerates. Stage 4. Dependence. At this stage, the brain has created a new normal. It functions only when the drug is present. If you take the drug away, the system crashes into withdrawal. This is a medical crisis. Stage 5. Addiction. This is the end stage. Use is now compulsive. Control is lost. Despite losing their job, health, or family, the brain's survival circuitry is so hijacked that it prioritizes the drug over everything else. So addiction is a progression, and the earlier we identify it, the better we can intervene. This is one of the most common questions patients and families ask. Why me? Why my child? The honest answer is, it is never just one thing. Several factors interact to determine vulnerability. First is biological factors. Some individuals have a genetic predisposition that makes them more vulnerable. Age also plays a role. Adolescents are at higher risk because their brains are still developing. Second, psychological factors. Stress, anxiety, and depression can drive substance use. Certain personality traits, like impulsivity or risk-taking, also increase susceptibility. Third, social factors. Environment matters. Peer pressure, drug availability, and socioeconomic conditions can strongly influence behavior. The fourth one is drug-related factors. Not all drugs are equal. Substances that act rapidly, are highly potent, or are taken through routes like smoking or injection tend to be more addictive because they deliver a faster dopamine surge. Fifth is early life experiences. Childhood trauma, neglect, or early exposure to substances can significantly increase long-term risk. Sixth is medical factors. Chronic pain, long-term prescriptions, and coexisting psychiatric conditions can all contribute to dependence. Seventh is behavioral factors. Over time, substance use becomes a learned behavior. Cues, like places, people, or emotions, can trigger cravings, reinforcing the cycle. And finally, the cultural and environmental context. Societal attitudes, media influence, and legal access also shape patterns of use. So, addiction is not a simple choice. It is a complex interplay of biology, psychology, environment, and the drug itself. Understanding these factors is the first step toward prevention and effective treatment. Now let's move to one of the most important aspects, the management of addiction. And remember this core principle: no single treatment works for everyone. Addiction is complex, so its management must also be multidimensional, combining pharmacological, behavioral, and social strategies. We begin with pharmacological treatment, which primarily helps by reducing withdrawal symptoms, controlling cravings, and preventing relapse. In opioid addiction, we often use substitution or blockade approaches. Methadone, a long-acting opioid agonist, stabilizes the patient by preventing withdrawal and reducing cravings without producing the same intense euphoria. Buprenorphine, a partial agonist, provides a ceiling effect, meaning it lowers the risk of overdose while still controlling cravings. Naltrexone, on the other hand, is an antagonist. It blocks opioid receptors completely, so even if the patient uses opioids, they do not experience the rewarding effects, helping to prevent relapse. In alcohol addiction, different strategies are used. Disulfiram acts as a deterrent. If the patient consumes alcohol, it produces an unpleasant reaction, discouraging further use. Naltrexone helps reduce the craving and reward associated with alcohol, while acamprosate works more subtly by stabilizing the altered neurochemistry of the brain, especially during abstinence. For nicotine addiction, nicotine replacement therapies such as patches and gum provide controlled doses of nicotine to ease withdrawal symptoms and gradually reduce dependence. Varenicline, a partial nicotinic receptor agonist, both reduces cravings and blocks the rewarding effects of nicotine, making smoking less satisfying. However, medications alone cannot address the behavioral and psychological aspects of addiction. That is where behavioral therapy becomes essential. Cognitive behavioral therapy helps patients recognize and modify negative thought patterns and behaviors associated with substance use. Motivational interviewing focuses on strengthening the patient's own readiness and commitment to change. In addition, relapse prevention strategies teach patients how to identify triggers, such as stress, certain environments, or social situations, and develop coping mechanisms to handle them effectively. Equally important is social support, because recovery does not happen in isolation. Family involvement can provide emotional stability and accountability. Rehabilitation programs offer structured environments where patients can focus on recovery without external pressures. Support groups and community networks create a sense of belonging and shared experience, which is crucial for maintaining long-term abstinence. So when you put it all together, effective addiction management is not about a single drug or a single therapy. It is a coordinated, patient-centered approach that targets the brain, behavior, and environment simultaneously, and that is what gives patients the best chance at sustained recovery. Now, let's talk about the complications of addiction. And this is where the real impact becomes clear. Addiction is not just a pharmacology problem. It is a major public health crisis with wide-ranging consequences. First, organ damage. Chronic substance use can severely affect vital organs. The liver, brain, and heart are especially vulnerable. Over time, this damage can become irreversible. Second, psychiatric complications. Addiction is closely linked with conditions like depression, anxiety, and even psychosis, creating a vicious cycle where each worsens the other. Third, social consequences. Many individuals experience social isolation, strained relationships, and loss of support systems. Fourth, financial impact. Sustaining substance use can lead to significant financial strain, job loss, and economic instability. And finally, the most serious risk is overdose and death. Loss of control over use can lead to toxic doses, making addiction potentially fatal. Today, drug use is a global public health crisis reaching record levels. According to the latest global reports, over 316 million people, that's roughly 6% of the world's adult population, have used a controlled substance in the past year. Of those, nearly 64 million are living with a diagnosed drug use disorder. While cannabis remains the most widely used substance, the danger lies in the shift towards synthetics. On a global average, men are roughly 3 times more likely than women to use drugs like cannabis, cocaine, or amphetamines. The cost isn't just economic. We lose nearly 500,000 lives every year to drug-related causes. Beyond mortality, addiction fuels a cycle of psychiatric conditions like depression and anxiety, making recovery a complex, multi-layered challenge. Understanding these numbers is the first step toward effective prevention and treatment. Addiction is a global challenge, but with evidence-based strategies, we can turn the tide. Let's keep learning. To summarize, addiction is not simply drug use. It is a brain disorder involving the reward, memory, and control systems, making it extremely difficult to stop despite harmful consequences. Understanding the pharmacology behind addiction transforms the way we see our patients. It moves us from judgment to compassion, from frustration to precision. That is the power of pharmacological knowledge, and that is why this topic matters. And that is a wrap on today's video. If this video helped you, please give it a thumbs up. And if you are not subscribed yet, now is a great time. I will see you in the next one.